Good afternoon. My name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer advocacy coalition working for 30 years on the goal of quality, affordable healthcare for all. We're pleased to be here to talk a little bit about some of the progress that we've made here in California and to try to forecast what I think are some of the big steps that we in California will take in the next year and the next couple of years to get closer to those goals. California's story on the Affordable Care Act is one that is related to the one nationally, but has definitely its own flavor. That we have had tremendous success with regard to the work of both implementing and improving the Affordable Care Act. We have millions of people have the new consumer protections, the new financial assistance. We've had, according to the last census, we had a drop of over 4 million Californians from our uninsured rate. That's a drop of over 10%. It's the largest drop of all 50 states in the percentage of the uninsured. And so I think that we can really say that the tip of the healthcare revolution or disruption is the word I keep hearing at a business school, we're in the center of it here, both in California because of the work that we've done to implement the health reform. And I think part of that is also the work that folks in California have done when those gains were threatened. You know, California gained the most from the Affordable Care Act, and so it had the most to lose when it was threatened in the congressional debates in the last 2 years. And so I think that voters, including here in Orange County, noticed that they would be losing some hard-won benefits and voted accordingly. And I think so. The last time I was here at the campus of Irvine was a indivisible debate moderating a panel with congressional candidates, including Harley Ruda, who's now in Congress, and then at another event with a former professor here at UC Irvine. So I think that this is really the epicenter of healthcare change in the country is here in California, both about what's going on here in the state and even here in Orange County. We got these successes because we took very specific action to not just implement, but to improve the law. And then the question is, now that because of the change in Congress, that law seems to be in place and more stabilized for the next couple of years, how can we actually take steps forward? One of the ways is, I know there was a discussion earlier this morning with regard to the question of sabotage from the Trump administration, and there was a long list of the various things that the Trump administration has done to undermine not just the Affordable Care Act, but our healthcare system in general. And I think the counterexample in California is that for each of those actions, California has taken countermeasures to try to shield consumers from the impact of that. So, the federal government cuts the open enrollment period for exchanges from 12 weeks to 6 weeks. We said, no, we want to maintain a 12-week period. They cut the outreach and marketing. We expand our outreach and enrollment efforts. They cut cost-sharing reductions. California helped develop this silver loading effort to reclaim the cost-sharing in other ways. There are a variety of ways where California has sought to try to make sure that we want to stabilize our healthcare system and make sure people have access to coverage. Just last year, there was a couple of other bills that were passed, including ones to limit what we would call junk insurance. These are plans that don't have to meet standards with regard to essential health benefits, with regard to out-of-pocket limits, with regard to denials for pre-existing conditions. And what we said, what they were called, these so-called short-term insurance products, we in California said we're just going to outlaw them. That is not the kind of product that we want to have in California, both for the people who would potentially buy them and then be trapped in junk insurance and not get coverage for the thing that they need when they need it, but also not to raise premiums for everybody else, which was projected by the Trump administration's own actuaries if those were allowed to destabilize the marketplace. We also limited association health plans, which had similar issues. on the issue of work requirements, which I know my colleague on the panel will talk a little bit more. A bill was passed and signed into law to prohibit those or other eligibility barriers in the Medicaid program that go against the spirit and the goals of Medicaid. So again, we are charting our own course. But I think the spirit of that is not that, and the spirit of not just the California policymakers has not just been to try to defend ourselves against the worst of what Governor Newsom now calls the vandalism of our federal government to the Affordable Care Act, but how do we actually take proactive steps forward? People, as the polling suggested, it's not that people just wanted to keep what they had, they actually see the need for improvement, in some cases significant improvement. And we've also had that debate at the state level, including the whole conversation of Medicare for all. I know in some of the earlier panels this has gotten a little bit of shade, so let me make actually the case for it. I think when people support Medicare for all, they are aspirational. I don't think that they're asking about any specific bill, HR X or SB 562 or any specific bill, but they're, I think, aspirational. That we want to get to a healthcare system that is universal, that includes everybody as a value, that everybody should get the care that they need. One that is progressively financed, so you pay based on what you can afford, not based on how sick you are, or one that is simpler. That just, I think that so much of our of this is just is people tearing their hair out about the complexity of our current healthcare system that is generated by its current fragmentation and its problems. And some, it's about the trust, whether it's that they have, whether in the insurers or in other parts of the healthcare system, and seeking at least a healthcare system that has some parameters and some values of what its goals is beyond specifically the profit of any specific entity. That being said, I mean, I want to be clear that as somebody who my organization has supported that goal and that vision, we also, if we're going to take single payer seriously, we also need to take the barriers to it seriously. And I don't disagree with much of the comments that have been made earlier about what those barriers are, not just the industry opposition, but the notion of how do you transition from the coverage that some people very much rely on to another type of system, and also just the financing and procedural barriers, including some of the constitutional barriers. And finally, the other question I would say is, especially for a state to do it, one of the big things that we would need is federal approval. And right now we have a federal government that seems to be hostile to healthcare in general and California in specific. So we wanted to figure out, okay, what can we do in the next several years that is aspirational but also achievable without federal approval? What is the limits of what can we do in California that actually helps people get the tangible help that they need, that they want, but that does not run into the barriers of a federal government that is trying to go in a totally different direction. And so we were proud to work with a coalition of over 60 organizations to try to last year around a notion of how do we get to Care for All California? How do we protect patients from some of the undermining of our healthcare system at the federal level, but how do we cover all Californians, and how do we address these issues of cost as well as quality and equity in our healthcare system? And so we were proud to have a broad coalition in support to basically create a critical mass to say, we appreciate the vision of a universal healthcare system, whether you call it Medicare for all or Medicare for more or single payer or whatever, but what's the work that we can get done now? And I do think that these are not either or questions. I think some of this debate has been overly stated as such, when in fact I think that these can be complementary to talk about what is the practical steps in the near term while you're also working at the longer term. And I think, frankly, somebody who seems to agree with that is our new governor, Governor Gavin Newsom. We laid out this proposal about how do you get to coverage for all, and we said we'll hope that Governor Brown takes a few steps down that path in his last year, and then we hope that the new governor will take it up and we'll have this path ready for him on day one. We didn't recognize he'd actually take it up on day one with a series of executive orders, but he in many cases did. By literally the day that he was inaugurated, he put out a series of proposals, and I'm going to go through them very quickly, and then the rest of the presentation will go into a little bit more detail. One was that he ran on a Medicare for All promise, and so one of his first acts was to send a letter to the federal government saying, what kind of permissions can I get to even start that conversation? We're not expecting an answer anytime soon, at least one that is more than 240 characters, but we are expecting, but we think that shouldn't be the end of the conversation. So what we're proposing is things like expanding affordability assistance in covered California to help people afford health coverage in a high cost of living state, reimposing a state level individual mandate so that we can stabilize the market and keep premiums low. Extend Medi-Cal to include undocumented young adults. We currently cover children in our Medi-Cal program, and to take another step there. Pooling state prescription drug purchasing so that we can bargain for the best possible price. He also took the effort of creating California's first ever Surgeon General to work on public health issues, including childhood trauma. So let me go into some of these things that we are working on and that Governor Newsom has already started on, starting on the issue of health for all. And if you look at the issue of California's remaining uninsured population, again, it used to be 7 million uninsured. It's now down to around 3 million. So again, nearly 20% uninsured, now down to 7%. So pretty big drop. And the big question for us is, how can we get down from that 7-8% down to that below 5% that most developed nations are at? What can we've gone so far? How do we deal with the remaining uninsured? If you look at the population of the remaining uninsured, about half of it are people who are excluded, Californians who are excluded from public programs because of their immigration status. So an obvious step, if we believe that our healthcare system is stronger when everybody's included, is to remove those exclusions. But there is also another slice of, another basically half of the pie, which is people who are in some cases eligible for help, who are legally residing. It's not a question of them being excluded from help, but who don't pick it up. And again, we suspect that that's about affordability, and I'll get to that in a second. On the issue of covering expanding Medi-Cal to all, regardless of immigration status, obviously this is something that would take state-only dollars. This is not something that the federal government would do their regular match on. But we also found that this would actually, there is a lot of offsetting costs with regard to emergency room care. At the end of the day, it is smarter to provide people primary and preventive care. It's a more efficient, more effective healthcare system. It does take more money. I want to be clear about that. But it is a much more efficient bang for buck system. And we think that if we actually do this for the entire Medi-Cal program, it would actually be roughly a 2% increase on the existing $100 billion program. So it is a relatively small amount of money for a big improvement in saying every Californian under 138% of the poverty level has access to care. There are pending bills right now, SB 29 and AB 4, to do that. And again, the governor has proposed to do this for young adults. Right now, we've already covered all children regardless of immigration status. We're one of 6 states to do that. And 200,000 children have access as a premise on that. And because of that action that California took 2 years ago, we can now say that that children in California have access to affordable health care in every classroom and every playground, and that has a benefit for all of us and all of our children. However, when those children turn 19, happy birthday, you've lost your health coverage. And we think that there is an opportunity here to take an important step forward. With regard to people who are buying coverage, I think the big thing is it ranges. We know that healthcare subsidies in covered California run out at 400% of the federal poverty level. We mentioned that that's around $48,000 for an individual, $98,000 for a family of 4. But we also know that that's That's not a lot in a lot of high-cost areas in California, and that when somebody just goes over that, especially if they're in their 50s or their 60s, that means that their premiums could increase significantly for just going over that 400% cliff, almost as much as double. And so we think that it's appropriate to go further. UC Berkeley had a study that suggested that 400% of the poverty level in nationally is equivalent to 500% in California and 600% in high-cost areas like San Francisco and probably Orange County. And so we need to have a system of financial help for middle-income people that recognizes the high cost of living here in California. But there are other cliffs in our healthcare system as well, even below 400%. The way the Affordable Care Act works is that it's a sliding scale. If you provide that you have to pay anywhere from 2 to 9.6% of your income on a sliding scale to buy a silver level plan. But there are cliffs for where the coverage goes up significantly because of premium and also because of your cost sharing. So just to give you an example, at 150% if you're just under 150% of the poverty level, your deductible is $75. If you're just over it, your deductible is $650. If you're at 200% of the federal poverty level, that goes up to $2,200, your deductible. So Covered California, actually, the legislature required that Covered California actually do a study to really look at this issue, and they have actually just in the last week put out a study that suggested how they could actually improve, if they had some money to provide some greater affordability assistance, how could they do that smooths out some of these cliffs, that provides some greater affordability assistance, and that would attract, combined with an imposition of a state individual mandate, around 750, 800,000 Californians into coverage. So putting a big dent in that question of the remaining uninsured. I mentioned the reimposition of a state individual mandate. That would, several states have done that. Massachusetts and Vermont. Massachusetts had one before the repeal. Vermont, New Jersey, and DC have reimposed one. We would obviously be the largest if we did. And not only what has that found is that actually that reduces premiums because it keeps people in the pool sharing the risk and cost of healthcare, but it also raises significant dollars that could go to greater affordability assistance, and that's what Governor Newsom has proposed. So we are actively working on this year in the legislature. I think that we will get a lot of this done, and actually we think that there's a possibility of more, that we could maybe go further down the path toward universal coverage with regard to the expansion of Medi-Cal, with regard to getting greater affordability assistance in Covered California, with regard to having some greater enrollment reforms to get people into the healthcare system. I want to spend the last section of my talk to be clear, though, that we recognize that it's not all about just getting more people covered. A lot of what we saw in the polling that Molly mentioned was about cost and people wanting reforms to make the base cost of healthcare more affordable. We've taken some steps in California, passing efforts to set up an all-payers cost database, to study the feasibility of a public option. And I mentioned before some of the Governor Newsom's proposals. So for example, on prescription drugs, we're really proud of the fact of the work that California has done to take on prescription drug prices. A couple of years ago, we passed a landmark price transparency bill, which is actually the reason that you're seeing some of those headlines about prices going up is because of the notice requirements in the California law, SB 17, that is letting us know about some of these increases. It requires purchasers to get advance notice when prices go up by a certain amount and to get a justification of those increases. We're also passed a bill last year to regulate pharmacy benefit managers, to have more transparency about what they're doing. And what Governor Newsom has proposed is to combine the purchasing power of all state entities Medi-Cal, CalPERS, Department of General Services, the state prisons, the state hospitals, and to basically become a giant bulk purchaser of prescription drugs. So that would basically create the negotiating power of over 15 million Californians and potentially more. And I think that the savings could be both because of the large purchasing power of the state aggregated, but also by getting rid of some of the middleman process. Right now in Medi-Cal, for example, the state has the Medi-Cal program contract with Medicaid managed care plans, which then contract with PBMs to negotiate a discount from the drug companies. And maybe there are some discounts and rebates and savings, but do those discounts and savings and rebate make their way all the way back up to the program and the public? And I think that there is some benefit to streamlining and standardizing that process. Another big thing that prescription drugs, just yesterday I was glad to be at a press conference with Attorney General Javier Becerra and Assembly Health Committee Chair Jim Wood about a bill on pay for delay, basically changing the presumption to make it illegal for the drug companies to pay their competitors to not put forward a less expensive competitor to their drugs, a practice that the FTC says has cost consumers over $3 billion over the last several years. To deal with, I recognize the slide earlier that prescription drug costs are not the only part of our healthcare problem. One is about just the rising cost of healthcare in general, including medical groups, including hospitals. And some of that is driven a lot by concentration. You'll have Richard Scheffler here tomorrow to talk about his research on the subject of why healthcare costs are extremely correlated, not with the cost of providing the care or the quality or the outcomes, but by the relative market position and concentration of any given provider. And you see that in California, where Northern California hospitals' inpatient admissions are significantly higher than Southern California, and that's largely due to hospital concentration. And so, we think that there is an important role to play to sort of try to address this consolidation. In much of healthcare, consumers really don't experience choice, don't experience competition. It's really, healthcare is not an area where you can say no a lot. It's not an area where you can comparison shop when you're in the hospital, when you're on the gurney of an ambulance. There's areas like rural hospitals where the notion of a competitive environment just doesn't exist. And even in those places where it might exist, there is increasing consolidation of these providers. And so the question is, what can we do? Well, one is that we should be very skeptical and mindful of the mergers that are happening, and we are seeing a lot of them. And we've been very active in the various hearings and proceedings that have been going on with regard to them, because we recognize that when these mergers happen, it's our money being used to consolidate market power, often for the purpose of raising prices. It often leads to reduced choice and competition. And there's also issues with regard to corporate behavior. At the end of the day, for some of these companies that have a bad track record of consumer protection or of other things, they should be made to make sure that they are going to be better before they are allowed to get bigger. And so that's one way that we've been active. But then another way is to try to increase the authority of regulators to take a look at this. One is, so for example, last year we had a bill passed to look at, to have greater regulatory authority over health plan mergers by the Department of Managed Healthcare, which is the agency that Cindy used to run, or Department of Insurance. We also have the Attorney General being more aggressive on these issues of consolidation, not only in the merger side, but also in terms of the overall consolidation. He has, for example, currently litigation on Sutter with regard to anti-competitive behavior. So let me wrap up by saying that there's obviously going to be other things that we will, I forecast, in the parlance of this conference, that there will be other bills as well to deal with the issue of cost and quality. Actually, tomorrow is the bill deadline in the state legislature, so we'll see what happens in the next week as ideas roll out. I think that there's a lot of interest in building on the good work that California has done, for example, on surprise bills, especially with regard to out-of-network ER use, because that is the one loophole in actually California's relatively strong protections, including some bills that we passed just in the last couple of years, is just this notion of an out-of-network ER, which actually to the patient doesn't make any sense. When you're going to the emergency room, there is no distinction about in-network or out-of-network. You're going to the emergency room. And try telling an ambulance driver which ER to go to, right? That's not even in the context, and so then why should you get the bill otherwise? I think that just earlier this week, we actually announced a bill on enhancing our rate review process so we can have a better sense of how good are insurers at negotiating with providers in relationship to Medicare. That Medicare gets a certain rate. Are insurers actually doing a good job of negotiating rates as a percentage of Medicare? And as I mentioned, I think the state has an important role both as a regulator but also as a purchaser. And again, Governor Newsom talked about that with regard to prescription drugs, but whether it is the Medicaid managed care plans in Medi-Cal or actually the qualified health plans in covered California, there's a role to play, and there's both going to be legislation and regulation to address that. So the last thing I'll just simply say is I think that there is an opportunity for California to help break this sort of either-or logjam that is debate that's happening at the federal level of how can we have both an aspirational agenda but achievable within the barriers that we have now. What can we get done right now? I think that there's an equivalent at the federal level. Whatever new president is placed is going to have to deal with barriers that includes 60 votes in the Senate, constitutional and financing restrictions, other things. And so I think that the conversation is not just what is your vision for the healthcare system we want to get to, but how do we get there? And I think that California can show the way. Thank you very much.